Both platforms perform good in terms of clinical endpoint test, stroke and heart failure hospitalization, non-inferior even in very small underlying both. The difference was in hemodynamics. Then we have the prosthetic valve dysfunction. In the hemodynamic valve dysfunction, mostly driven by the gradients, by the mean gradient on echo more than 20, or patient prosthesis mismatch, which showed the superiority of the EVOQUE valve in those scenarios. But and then if you look at the SAPIEN 3 low-risk trial, again, they selected any size of valve, even in the small underline, still no difference with surgery. So this is a point of discussion between how much this is, it means really a lot clinically, but we have, I think, smart trial now, we have 2 years, we have probably to wait a little bit for longer follow-up, and we will see. The important study that took a lot of discussion is if we intervene early on asymptomatic patients, and that's the early TAVR trial presented by Philippe Genereux and published in the New England Journal of Medicine. So that study randomized 1-to-1 in patients who are by stress test negative, so they are asymptomatic and they have severe aortic stenosis. Shall we do conservative watching and monitoring, and or we intervene with TAVR? It was a TAVR arm. There's no surgery in this trial, and the primary endpoint was superiority on all-cause death, any stroke, or unplanned cardiovascular hospitalization. Keep in mind of that heart failure hospitalization is a patient switched cohort, and that's considered as hospitalization. That was criticized for this design. And then what did it show? This is the outcome in terms of the primary outcome between doing the TAVR on those asymptomatic patients or watchful monitoring. That was a superiority, significant superiority for the TAVR arm. But needed to treat at 2 years was 6. The difference was not in all-cause death. It was not in a stroke. It was mainly in unplanned cardiovascular hospitalization. But you can see that peak at 6 months. We will go over it and show how it is. What's mainly the patient who converted to AVR. Those patients were asymptomatic and start to show symptoms, and we'll talk a little bit about it. Then 26% at 6 months. Half of the population, converted at 1 year to get the procedure done because they had symptoms. The median time was 11 months, and most of the patients converted to TAVR by the 2 years follow-up in the study. So why did they convert? Either by symptoms or by severe progression or worsening AS with peak velocity more than 5, with the EF drops of or 3 times the BNP. And they have 2 groups between progressive signs and symptoms, like moderate or like advanced symptoms. They showed also difference in outcome with that, and most of the patients had advanced symptoms, especially after 6 months to 12 months. The rest had progressive symptoms, and most of these, this is why they converted. From this study as well, we see this is a recent study. See the outcome of TAVR is impressive, as we see now in practice, and that impacted the recent ESC Guidelines announced in 2025 from performing TAVR in asymptomatic severe AS. It's very reasonable if the EF is less than 50%, with other 1B, but also it's a 2AA if the patient has a very low procedural risk. So they added how the procedure is just straightforward. TAVR was very complex, and they have severe high-grading AS, but it's very reasonable to be offered to patients with asymptomatic AS. They have severe calcification. If the VMAX is progressing, it's like we're having a dynamic point here, or high BNP, or again the EF lower. The last point on the aortic valve is the ALIGN AR trial. So we're talking about aortic regurgitation. That was the largest cohort published ever so far, with the largest part in the Lancet. 700 patients, 180 were in the pivotal trial, and the rest 500 were from the continued access of the Jena valve trilogy valve, which showed that was the primary endpoint from the aligning arm. It was at the shorter performance of the valve, which was impressive. But besides that, it didn't have a high pacemaker, around 21%. But it worked. And this is the 2 years follow-up of the whole cohort of 700 patients, which shows a good performance in general, 98% procedural success, and they divided in tertile. The patients who had our LV remodeling performed the best. And those patients who did not have any LV remodeling, they did worse in terms of mortality and heart failure hospitalization. Patients with or without pacemaker, they didn't have any difference in outcome in this study, and that's also shown in the ESC guidelines, a little bit of recommendation, but still to be considered. The last one I wanted to add, it's very interesting. They used the same general trilogy in AS, aortic stenosis. There is a small cohort from Germany, and it showed 98% success for 2 out of 43. Interestingly, the pacemaker here is 5% compared to 21% in the AI. So you probably don't need too much exercising, and that's something to keep an eye on. That was published in JACC. Just for that's a great review article, and also published in JACC in 2025, which is summarizing a bit of what's going on in the aortic space. Just want to put it there for wants to read. We'll go from the aortic quickly to the mitral. Summit MAC presented by Paul Soraja, DCT, great study in mitral error classification patient cohort treated by the transapical Abbott tendine valve, and it showed very acceptable results for the high-risk procedure in very, very high-risk patients, very sick patients. 100 patients, single arm, 1 year follow-up. The all-cause mortality, freedom from all-cause mortality, 60%. The goal for superiority was 45%, so its endpoint, 100% more reduction, and improvement in quality of life and symptoms. That the deadline is now FDA approved since May 2025. We've probably been waiting more and more on transeptal devices for mitral valve replacement. The INCIRCLE trial was presented at TCT and published simultaneously in the Lancet by Riker was published by Guerrero, Myra, and then it showed no intraprocedural death in the whole study, no LVOT obstruction in terms of hemodynamics, no conversion to surgery, and the primary endpoint, which is death heart failure hospitalization, was 25% in the for the world of 45. Very significant, extremely positive results from the study. You can see the outcomes here, and then warrant the M3 an FDA approval in December, just last month, which is the first transeptal mitral valve replacement to get FDA approval. Getting it soon to our patients. There's a lot of unmet needs for this space. There is a high life valve just got CE marked in Europe. We don't have it yet in the US approved, but I think in the coming 2 to 5 years, if we keep doing these presentations every year, we will add 1 TMVR device probably every year.
Question. How do you replace them when there's a malfunction?
So the replacement, these are all transcatheter. The one was transapical, the first one, and this one is transeptal. Transeptal approach to replace the valve. There are multiple designs. Either you anchor on a duct like this one with this design, or you design and put in a 2-step procedure. There are others, they are just anchoring on the annulus with the edges, and some are leaflet anchoring. So there are multiple ways to make sure your valve is anchored, and at the end of the day, you will have the valve completely replaced by opposition of repair in the clip.
The question that I have is, do that right the first time. Now it's 12 months later or 18 months later, there's a complication. How do you replace that valve?
Yeah.
Out of the surgery.
That's a great. Some of it depends how the failure mechanism is. The failure mechanism is a dislodgement or leak. Yeah, you might need to redo and you have to do a surgery. And those patients are high risk for surgery at baseline. But mostly you can put a valve in valve so you can get an aortic valve, but we're expendable and go inside.
The human tissue is strong enough to go back in there, take out whatever scar tissue is developed around this valve, and then reconnect it to healthy tissue.
Yeah, that has been done a lot in the TAVR space. So we have bioprosthesis, surgical, then we do redo surgery. So we do redo surgery on forever. And now we have doing a lot of redo TAVR, so the TAVR explant, so TAVR valve in aortic position, you take it out and do. This definitely is a more complex procedure. There is a lot of root replacement that will be needed, unlike you do in a first index procedure. With these ones as well, it will not be an easy procedure. But there is a percutaneous option. You can put a valve inside the valve. So that's probably will be the first slide revisit, which will be number one. Keep in mind, Doc, this is very high risk patients. Durability is very good up to now 2 years. And I expect we do the valve in mitral valve now for more than 10 years. So failed bioprosthesis in mitral position, we put a sapien in. So it's or valve in ring. So they mimicked that. We didn't have the ring, so we put a dock and we put the valve. So because we have to enter the valve. So I would expect the durability to be good. Most of the re-expansion hopefully will be also transcutaneous because those patients at baseline they were high risk for surgery. Finally, a couple of words on the tricuspid. We had the TriLuminate trial 2 years now, 2025. The first year follow-up was published in 2024, and it gave the Abbott TriClip, which is edge-to-edge repair on the tricuspid valve, the FDA approval last year. Now we have a 2 years follow-up. The TriLuminate first year showed non-inferiority. We got superiority in terms of heart failure and hospitalization when we got the 2 years follow-up. Very good data for this technology, improvement of quality of life. And you can see the improvement in tricuspid regurgitation, especially in the crossover. So I think a lot of outcomes are driven by crossover, very similar to the early TAVR. And this is how we see if we do, they improve. So we have to, it makes sense to treat those patients if they are anatomically favorable. And this procedure shows good safety outcome. This is TriClip 2 years for edge-to-edge repair. Then for the replacement with the EVOQUE valve, finally they had the TriScent 2 trial at 1 year as well, showed non-inferiority. With this one, it showed superiority if you take the most severe TR. And you can see when you have massive intervention at baseline, you had superiority on mortality and heart failure hospitalization in this cohort. With the replacement, you had eliminate TR basically. It was also very promising data. Finally, what happens with the EVOQUE we're doing in the US, the Registry real-world data, 1,035 patients, 77 years old, mostly female and had AFib. 40% had pacemaker. Surprisingly, primary was site reported, and that's the outcome. Success is 98.5%, 0.8 converse surgery, and they were mostly discharged home. Impressive data, way better than the TriScent trial that shows probably the learning curve, and the cardiovascular mortality at 30 days only 2%. For the EVOQUE, the major bleeding was 1.3%. Just to remind you, for the TriScent trial was more than 10%, so it's like 10 times better we're doing compared to the recent trial. And the pacemaker was 15% compared to 24% in the TriScent trial. So this is what's happening in real-world data. You have a practically elimination of TR and also improving in RV, hemodynamic RV function. So definitely this was reflected with better clinical outcome. So in conclusion, in 2025, we have expansion in treatment in terms of early TAVR and early intervention. Long-term data showed us, at least for TAVR's perspective, TAVR is performing great up to 7 and 10 years. And definitely a lot of innovation in mitral tricuspid, both in repair and replacement. So we have to do better patient selection to choose what to do for which patient, but definitely we will have a way better outcome with the. This is it was very good year for structural heart in terms of innovation, also like outcome and long-term outcomes very assured.
Thank you. Any questions? That was kind of a tour de force, kind of
A little bit.
whirlwind.
Yeah, it's a lot of stuff, but honestly, it was. But just one word. The difficulty was like it's difficult to design the study with these because most of, as you see, it's not sham control. So patients know that they were like randomized to medical care or like watchful monitoring, and they come up after 6 months, they have symptoms. So this is very tricky, and definitely it's not a sham control in those TAVR or the tricuspid tier. So the conversion rate is a fact that is coming in those design valves studies that can make it not perfect design. I don't know how to do better if you cannot do sham control. This is tricky, but if you that's something to take in consideration. That's why, again, with all these data, still you have to have a personalized decision. Who is the patient? What probably surgery if they are very young and healthy and have good anatomies, especially bicuspid, have to be careful. And so if you take an objective and say take patient by patient, I think it's all about patient selection. If you take those studies and offer the procedure for everyone, I think that's a little bit wrong.
Question that I had is there's several patients of mine up north that presented with AFib, and then I listened to their heart and they got severe AS. And then, their EF is on the low side, so there's a TAVR. So they're indicated for TAVR. But is that AFib has that been looked at as a marker for, like a surrogate for worsening AS? I mean,
well, I don't know worsening, but what I know from the practice, it's definitely effective to miss a lot of AS. Because a lot of AFib patients have paradoxical low flow, low gradient, even they have normal EF, and they were missed for years. Why? Because they have a normal EF, they are an AFib, they have a little of MR, probably a little of tertiary TR, AFib-induced TR, and their mean gradient is 20. They kept, telling them they have moderate AS and they have to keep monitoring, and now it's like calcium score now at 4,000. So we had a lot of these. Unfortunately, they are a little bit late for treatment, and the LV is already, they have a real HFpEF. So I think this is where it's sad for the outcome. I mean, it's all, I don't know which one is chicken or the egg, but this is part of the cycle of these are definitely already remodeled atria, from orthodontists, a little bit about what's going on in that field, but definitely those patients are a little bit on the late side. And, rather than going orthodox and treat all the patients with asymptomatic TS, probably a personalized decision, good discussion with the family and the patient. And, we don't need to treat all of them. If I take what I take from this study, but I showed TAVR was very safe. If we have an option to do another TAVR down the road, I think the TAVR is low risk as it's claimed in the guidelines. I think it's reasonable to talk to the patient about it. If the patient has one valve in their lifetime based on their anatomy or their TAVR is complex, I think they can wait.
because this is 3 patients I've already encountered. One of them was 84 TAVR. She already had AFib. And then, after, the only reason when I listened to her, she had severe AS. And so we had to take care of the AS first. And now she's going to Dr. for AFib ablation. But I mean, it was the presenting thing was AFib. And then it was the AS was just by exam, I know.
And probably she had AS and she got AFib, and the AFib made her probably symptomatic.